I will briefly introduce our speakers. Orion was at the Arizona Department of Health through 2014 and led the Arizona Border Infectious Disease Surveillance Program. Then moved to CDC through 2022 as the CDC Mycotic Disease Branch Staff Epidemiologist, and then subsequently moved to Oregon. He was working with the COVID-19 plan at that time, and now he began a new state program as public health manager for carceral setting in Oregon. Dr. Sunenshine, our second speaker, is in Maricopa County. She has also had extensive experience at CDC as a field officer assigned to Arizona since July of 2006 and served as the Arizona Department of Health Services for 4 years at Maricopa County. And I'm going to summarize everything because we're going to save time for you guys to talk. And Mariel Marlowe, who will be joining us via Zoom, I assume you are there, also is in CDC, has related activities to CDC National Center for HIV, Viral Hepatitis, STD, and TB prevention, and serve as the co-chair for the Correctional Health Work Group. I appreciate Orion to bring all these great speakers with him, and thank you for your time today.
Thank you so much. Thank you, Dr. Donovan, and thank you guys for allowing me to be here today and getting to be back here in Arizona and in Tucson, a favorite place where I grew up. So I'm excited to talk to you and excited to have a couple of my colleagues and good friends share with you as well. And I think, you know, as we talk about advancing equity in public health and collaborating with our carceral settings, I truly think that this is a part of public health modernization. And I need to know, so quick outline, I'm going to go over some carceral systems. I'm going to talk about one of my favorite diseases, COPSI, valley fever, talk a little bit about COVID and some of the work that happened. Our latest pandemic was the MPOX, talk about a little bit of syphilis and the struggle to prevent overdose deaths, which we're really in a crisis, I think, across the nation and seeing a lot of that in the state I work now. So what is carceral? I mean, the definition would be of relating to or suggesting a jail or prison, but I would challenge you all to do some research, to look, to start seeing. I'm trying to normalize this phrase a little bit because I don't think that there's an appropriate term when we're talking about people's whole trajectory through our correctional system back into community. And I think if you're talking about a jail, we're talking about a rotating door between houselessness and shelter and streets. And so I'm trying to talk about carceral in a much broader sense than just in the walls of a prison or jail. This comes down to some of our policing practices that have long been in place, you know, really heightened in some places where poverty is a big issue. We can talk about, you know, some of the labor dimensions that stand out. You know, we use our prisons as a labor force for a lot of things as well. And it's really just some of the mass incarceration in the state when we look at has been a major sense and a major equity issue. And then I think we also have to talk about when people are transitioning back out to community. There's been some nice studies in Washington State that people who have been incarcerated in prison are 3.5 times more likely to die from overdose, suicide, murder, and cardiovascular disease in the weeks after they get out. And so we really have to think about safely returning people back to community. And I would be remiss to start talking about corrections and carceral systems if we didn't talk about the racial disparities that exist. I know this is a little bit of a busy slide, but basically our brothers and sisters of color are way overrepresented in our carceral systems. And it's part of the model of the systems and the policing practices that have established the mass incarceration. And I now work at Oregon Health Authority. I went there to become the surge capacity epidemiologist in February of 2020. And there's a big push for equity. We're trying to eliminate health inequities by 2030. This is going to be a pretty lofty goal, but there's a lot of inequities out there. It's exciting to be in an area where I get to really focus on trying to address some of those inequities. And, you know, I think each one of these inequities that are listed there really intersects with incarceration in different ways, and we'll touch on that. I think that, you know, when we talk about people that are in and out of jails, we're talking about inequities upon inequities. Racial and ethnic disparities, there's houselessness and chronic homelessness, the chronic diseases that are a major issue, the communicable disease, and I'm going to touch a little bit on that because of the audience here. We have substance use disorder, which I would really challenge, you know, people to start addressing and thinking about. On top of behavioral health challenges, the social isolation and disenfranchisement that comes, family dislocation and child welfare involvement, underemployment, unemployment, poverty, poor nutrition, and just a lack of access to an adequate system of care. And I should say, as I'm talking about carceral, that's a big term for a lot of things. And if you've seen one jail or one prison, you've seen one jail or one prison. They're vastly different, and it really takes some time to understand the complexities of each of these institutions in their operations. So the way that I'm going to start this is kind of my trajectory. As mentioned, I worked here in Arizona for about 6 years. I ran the Border Infectious Disease Surveillance Program, doing active surveillance for a lot of different diseases, and worked closely with the hospital here, as well as IHS and others along our border region. You know, one of the places that this started to intersect with the carceral systems is people with active TB being deported. And we knew that those people were very likely to try to cross again. But I built a system and worked with ICE on having a notification, a meet and greet for active TB cases. They would call me and they'd be like, hey, I'm going to be at the border in an hour. So I would scramble to call Sonora Secretariat de Salud, make sure that we could have a doctor there from Sonora in Nogales to meet the person to continue treatment so that we didn't develop resistant TB cases. I then went to CDC, but again, this being my favorite disease, I got to work on one of my favorite diseases, valley fever, COXI. I got to do a lot of work with their Dr. Galgiani and Dr. Donovan while there. But in California Department of Prisons, they build prisons on some of the cheapest land that they can find. And they had huge rates of valley fever in there. California has one of the largest correctional systems in the country, with nearly 95,000 people in prisons, 2,000 in camps. These run a lot of, more than 60% of wildland firefighters are people in custody. And early on, they started seeing really high rates, especially in the Avenal and Pleasant Valley prisons. So they started trying to do some different work with experts to prevent disease. As you guys may know, valley fever for epigenetic reasons can really be, it can more likely to disseminate and be severe in people of African American and Filipino descent. And they were seeing quite a few cases there. You can see the rates in those prisons are nearly 4,000 per 100,000. And so CDC and NIOSH helped California Corrections looking at some of these places where the disease was not going to go away because of where the prisons were located geographically. right in the Central Valley. And so they started doing some different prevention measures as early as 2007, trying to move people that were at high clinical risk, immunocompromised, and others out of those really high rate prisons. 2011 started doing sealants around there. This was kind of an old way to prevent cocci, but if you're not letting the dust kick up and blow, then you might prevent some. And then really trying to do environmental controls at the prisons, 2013 and 14. This also started some ethnic and racial restrictions, medical restrictions on those for people that might be at higher risk for disseminated disease. There was a cocci skin test that was reinvented or remanufactured and back on the market. So we also did some work with California Corrections to offer skin testing to look for previous infections and people that are thought to be likely immune from a secondary infection, and allowing that as another prevention measure. And then continuing to provide soil sealants. There was a lot of work to close down air structures to restrict yard time and when construction was going on in those. And what we found is that this actually was effective in trying to reduce the rates. As you can see, especially in some of those highest risk populations, on the left, you can see in 2011 what some of the case rates looked like. And you can see that, there was even some statistically significant reduction in cocci cases there in African Americans, but did reduce some of the caseload. So with that, I just want to remind you guys all practicing and in ID here in a hyperendemic area and in this, that we know that a large proportion of your community-acquired pneumonia patients are likely to be coccidioidiomycosis. So the sign just to think fungus, I used to put these up in your ER room years and years ago, but just try and think about it. There's been some really great work on trying to understand some of the diagnostics, and you guys have a great resource here with the Valley Fever Center for Excellence when you do identify cases. I'm going to go through kind of a quick potpourri of different infectious disease and place that might impact this. And so when I moved to Oregon, I did become the prison guy. Wasn't my intention. I had moved there to become the surge capacity epidemiologist, but I saw it on the wall. We were investigating the first case at UC Davis, the first locally acquired case when I left CDC. And I said, this is going to be really challenging in our prisons, in our jails, our shelters, migrant seasonal farm worker housing, and workplaces. And so I worked on our work plan for a state as those, and then I really continued to work directly with our correctional partners, Oregon Youth Authority, Department of Corrections, and later with county jails and juvenile detentions. And I did that all through the pandemic, meeting with leadership weekly. And so this was the pandemic that just kept going. You guys all know that. And when you think about COVID in corrections, it was such a balance to try to eliminate transmission, to think about severe disease in those that were high risk, prevent death. But we were also balancing the mental health. We had shut down a lot of the programming that is imperative to maintain that mental health in corrections. And we stripped visitation away. And for people that are locked up, like having that connection to community is extremely important. And we knew that especially for the kids that were in our Oregon Youth Authority. So it was a constant balancing act to try to do the best that we could to protect people that were in custody, but not just from the pandemic, but also from the other behavioral health challenges and the other risks that are inherent in these settings. And so trying to find a great way. But we were in our Department of Corrections and our OIA. I personally was going there a couple times a month to talk to youth, to talk to adults, talk about the vaccine, talk about the pandemic. And we got vaccination rates up into the high 70%, much earlier than before they were that rate in the community. And then we rolled right into the next pandemic. Then we had the MPOX pandemic coming around. And this was just a new one. We needed to think about this differently. I think everyone was sick of pandemics by that point. So really trying to shift a focus to say, we got to think about this one differently. There was actually already a vaccine that was available. It was less transmissible, but there was a lot of stigmatization with this disease, and we really needed to focus on that. And that stigmatization was even exemplified when you talk about in a correctional setting where no one is having sex and no one is doing anything that they shouldn't. So we had to focus on different ways to screen and treat, and we had to find new ways to make sure that people were still able to talk about this in a secure way. Unique challenges that still congregate spread, could be high spread. People are living there for 24 hours a day, 7 days a week, shared facilities, shared showers, shared towels. Actually, our Department of Corrections is contracted to wash just about all of our hospital laundry in the state of Oregon. So we also were having conversations about doing that safely. And the unique risks that we saw that were posed by long outbreaks and isolation periods. And this had a much longer isolation period. But we know that for infectious disease docs, this is your patient population, that a lot of people that are in and out of custody are at this intersection where they might be a BIPOC person, they might be living with HIV, they might have transactional sex. These might be people experiencing houselessness. This could be people with substance abuse disorders. This could also be people with other conditions that might lead to more severe disease. And so we needed to focus on destigmatization and identifying cases early. We did pretty good in the state of Oregon, and we ended up not having any in our correctional settings, although I do have partners that did investigate other cases elsewhere in the country. But it was about doing early interventions. We did grand rounds and lunch and learns with all the providers in our Department of Corrections and our Oregon Youth Authority to make sure that they could identify and test quickly and early if they did suspect a case. And this just to point out the cross connection to people with other STDs that are also there, and also Hep C vaccinations for the number of the reasons that we have mentioned already, that this is a shared risk. And we really talk about this as a syndemic in my state, that this is HIV, Hep C, other STDs, people who choose to use drugs, all at this intersection. And so we also had to think about an intersectional approach to vaccine distribution because this was limited. And so really wanted to focus on people that were incarcerated. And this overlaps with a lot of the other groups that were prioritized early on when that vaccine was not as available as it should be. Touching on another one, welcome back to Oregon, syphilis. These are rates of syphilis that you can see where they were once upon a time. We were almost down to no cases, and now it is through the roof. And this isn't a problem that's unique to Oregon. This is really something that's going on across the country, and it's a huge issue, and we need to try and do as many things as we can to address it. Oregon was 9th in the nation for primary and secondary syphilis. Yeah, I think you guys can see Arizona beat us on this one. And congenital syphilis, early syphilis increased over 900%. I realize this is not all of our cases, but these are the most severe cases that we need to address and be concerned about. And we were down to 0 in 2013. You can see that we're up to almost 40 cases in 2022, and that might still be lagging. You know, when we look at what was found out about interview of cases, we know that there's a lot of the people who inject drugs, people that use methamphetamine because of risky sexual activities, people that have transactional sex. And here, criminal justice involvement, there was 4% and then 3% respectively. And But when we actually went through and tried to do a deeper dive into this, so this is just of our 2014 to 2020 congenital syphilis, 48% were houseless or unstably housed, and 61% had history of criminal justice involvement. 25% in the 12 months prior to case identification. So this is at an intersection that a lot of these people, this might be the only opportunity for a public health intervention, is the time that they spend through their stay. We need to test people. This needs to be happening in our jails. This needs to be happening in our reentry centers. This needs to be talked about and shared, because we're not going to get ahead of this new epidemic unless we start doing more. And then I'm going to touch on the overdose prevention, an ongoing struggle, really at the center of it in some of our state, but it's across the country. I think you guys have seen it. There's media and there's movies out now about it. It's an ongoing crisis. We were already in a crisis in 2020 in Oregon when I showed up there. 2 out of 3 Oregonians knew someone with a substance use disorder. Then we had the pandemic that broke down a lot of the networks and the resources that were offered to people. We had ranked 1 in the nation for meth and prescription opioid, 2 in the nation for illicit drug use, 12 and older, and 3 in the nation for any substance use disorder. And we have a changing epidemic. This used to be overprescription of opioids. It is now fentanyl. It's illicit fentanyl. It's not even real fentanyl, and everything else. And it's all combined. And so this is really changing the dynamics of it. And it's less from the medication, but now we're having even more overdoses. If you look here, these are our drug death overdoses. And you can see in the blue line at the top is all drugs. But a lot of this is really being driven by the fentanyl and the meth. They're in the gray and orange lines. Cocaine and heroin have fallen out of fashion a little bit, and they're just too expensive, but the fentanyl is just flooding the streets. You can see here Oregon versus other states. This is just percent change in the last 2 months. In the last year, we are up 23% overdoses. We're trying to get ahead of this, but that horse has left the barn, and it's a huge issue. And as mentioned, this is really being driven by the fentanyl. Here you can see some of the data from our High Intensity Drug Trafficking Association and the drugs that are actually seized, and it is the fentanyl, and it's powdered fentanyl, and a lot of it's just manufactured and illegal fentanyl. We have a really disproportionate impact of our overdose deaths. These are happening in our white Oregonians, but there is a much higher disproportionate impact in our Hispanic and African American and Alaska Native populations. And it's unfortunate. And here I'm showing you some of the age categories, really just to point out that this is hitting our young people. These are 25 to 44-year-olds. These people shouldn't be dying yet. And there's a lot of work that we need to do to try and get this under control. Here's our rates by county, just so you can see this is really pretty ubiquitous across the county or across the state. There's some really small populations where there's probably some missed reporting and limited data, but it's across there. When we did just a look to see, there is on death certificate data people that have previously been incarcerated. I think this is a big underestimate. We had about 9 cases during this time period that died in custody because, being honest, people still use drugs while they're in custody too. And these are people that were reported as recently released from their death certificate and the medical examiner. This is about 99 cases. at that 9. 14% had a substance use treatment going. 14 had a previous overdose. We know that people that have already overdosed are at really high risk to overdose again. Nearly 40% had a disclosed mental health issue, and 46% had opioids and stimulants defined as the cause of death. We also have the new kid on the block now, xylazine. This is an animal sedative tranquilizer. It started on the East Coast. It was really big and hit Philadelphia and Chicago and has moved out west. We're seeing it increase, and this is not an opioid, but it's being mixed with the opioids. So now that Narcan doesn't affect the xylazine, it still should be administered because it's almost always in polydrug form. But now we have something else to think about. So in addition to the Narcan, you really need to think about rescue breathing, because this just reduces respiratory rate and other things that you would expect a sedative to do. And it causes these really gnarly wounds that are not even at injection sites. These can show up all over on the body, on extremities. And so now we have to be thinking, I spared you guys some of our clinical pictures of these wounds, but we're seeing them in Oregon now. This is coming up. You guys are going to be seeing these patients when it gets here. I'm sure that there's some here, but we can only expect that this is going to continue to increase as the drug supply becomes more and more contaminated with this. I work in a really complex landscape where we have the secondary impacts of COVID affecting our overdose, massive increase in fentanyl supply across the Western states. We implemented Measure 110, so this basically decriminalized drug use in Oregon with referral to behavioral health. I think it's a little too early to attribute population health outcomes. There was one paper that was recently studied that said that our overdose did not increase due to that. Fortunately, but unfortunately, so Measure 110 was initiated in February of 2021. We also have a lot of funding that is building a behavioral health resource network, or BURNS, but that funding didn't come around till May of 2022. There's still a need to really build and grow a behavioral health workforce that's not there immediately. And so we have to continue working on this. I'll also mention that we're in the process of negotiating with CMS on a Medicaid waiver for 115. This would expand SUD services and housing. This would allow people in custody with 90 days or less prior to release to actually have their Medicaid turned back on and start doing some different stuff. So this is going to take some time. Ours is expected to be approved in the next calendar year, but it's systems work, it's the hard work, and I realize it's going to take time. I just hope that there's opportunity. We also have opioid settlement funds. They're being operationalized both locally and in the state, and have been meeting with those groups and talking about the intersection with carcerality. We know that this really requires a culturally specific community response. And when we think about this, we think about there needs to be the SUD, needs to be tied to mental health services. We need to talk about harm reduction in a way that's not stigmatizing and meet people where they are, because not everyone's going to be ready to come fully clean, but we can talk about ways that they can be safer, ways that they can reduce risk for some of those infectious diseases associated with injection drug use. And we got to talk about housing support, and we got to talk about other pain management resources and tools. I'm doing a lot of work with the jails in my state to give naloxone at release. Our Department of Corrections gives everyone, regardless of whether they're in an MOED program or not, 2 doses at release. And I've gotten about 5 or 6 of our different jails to start doing that. What tools do we have? That's the one. We need to flood the streets when we're seeing a spike or increases in overdoses. It needs to be in people's hands. I never thought I would be, but I carry around Narcan in my bag with me now in Oregon. We have great we have a clearinghouse where we're giving that out free of charge to nonprofits and others in the state. We're giving it to firefighters, we're giving it to EMS, we're giving it to the police if they'll do leave behind, probation and parole. We gave our Oregon Youth Authority 35,000 doses to give probation and parole. A little too late because they had just lost one of the youth about a week before we got that done. There's also some great signs that we have, and just trying to get this out and everywhere that we can in different places, and make sure that people know how to use it when they have it on them and they know what to do. And I think we also have to talk about, some counseling and some management of what that might do to someone's mental health when they do bring someone back. We got to talk about peers, because I can sit up here and talk to you guys and it's great. But when we're talking to people that use drugs, that are involved with the carceral system, they want to hear from someone that looks like them, talks like them, knows the road that they've traveled. I don't know it enough. I keep trying to hear stories and learn, but I cannot say enough about how important people with lived experience are to carry that message, and think about people that are in recovery, that's such a stronger message. And so we're working with Prime Plus peers that are funded through the state. We have peer recovery mentors that are in our Department of Corrections right now. If people get caught with an infraction, then they can go to a peer recovery mentor and go through a program rather than have that on their record. And I'm trying to get more of these peers into the jail to really help talk to people and work with them, because they might take them to the treatment center when they leave. If the jail just releases them, they're just going to fall back to what they know and where they know to go. And these people really support any change, I think, in that harm reduction vein that we were talking about. They're willing to meet people where they are and just talk about what they can do. This is a super busy slide. I just think we could also talk about expanding MOUD. We're trying to work on a legislative concept in Oregon to have our state legislature fund MOUD, or we're going to talk to the Opioid Settlement Board. We're going to find a way. And once we get that Medicaid waiver, we'll be able to drastically expand that. We need to do it in a way that's minimally invasive to people's lives too. And when you think about people in this rotating door between jails, shelters, and housing, it's super hard. With that, thank you guys for letting me share all the good news. But I think that there's a lot more that we can continue to do if we work together to think about improving public health and improving collaborations with these carceral settings, with these correctional partners, and with the community-based organizations that are helping people land when they get out. And so it takes us all coming together to come up with system changes and real improvements. I think there's going to continue to be many threats and ongoing challenges to public health and carceral settings. The COVID pandemic pulled a blinder off of a lot of that for other places in the states. I'm trying to build a public health network of people that are working with correctional settings from other states right now. And we just know that oftentimes people, when they come through custody, might be their only chance to have that touch of public health. So think correctional health really is community health. The healthier community, the healthier that we send someone out of corrections, the healthier that they're going to be in community, and we're improving our overall community's health. Much appreciation to all my team, and this is much shorter than should all be there. And with that, I'm going to pass it to my colleague, Dr. Rebecca Sunenshine, to give a little bit more flavor and local characteristics to this. And then we can take questions at the end.
Good afternoon, everyone. Let me put this on slideshow. Something. You guys see it? Can you guide me there?
Oh, can you go all the way up?
Is it this one?
No.
No?
Yeah, that one. Try that one.
That one, right?
Oh, God, that looks totally different from my usual. Okay. So thank you so much for having me. This is such an honor. I am here to bring you some more local. I'm not from Pima County. I am from Maricopa County, and I apologize for that. I know how you guys feel. And I will tell you that following a presentation by Oregon in Pima County is a little painful. I don't know if you know this. Our political milieu in Maricopa is a little bit different than yours. So a lot of times you guys have already done a lot of the things that we're striving to do. We have a ton of people, and we're working really hard to make sure that all of these things that Orion is talking about are at the top of people's minds in Maricopa County, which, as you know, is very populous, 4.4 million people. So I just want to briefly introduce you to Maricopa County Correctional Health Services and our jail system and how it works together with public health in Maricopa County, really to exemplify a lot of the things Orion talked about. This is my CDC disclaimer. Just so you know, I did meet Orion at ADHS when I was a CDC assignee there. After leaving Oregon, where I did my ID and my internal medicine training. So we just keep meeting up with each other, and I'll tell you how we ended up giving this talk in just a few minutes. So the Maricopa County jail system is one of the largest county jails in the entire country. It books up to about 100,000 individuals per year. And the average daily population before COVID was about 8,000, and it's actually a little bit lower now, right around 7,000. That is a lot of people. That is just a constant revolving door. You know that pressure that you have to see patients in 10 or 15 minutes? Can you imagine seeing 4,000 to 7,000 people every day? It is, you don't have, 15 minutes would be a luxury. So the male to female ratio is 7-to-1 in our jail system, and approximately 30 to 40 pregnant patients are in the care of correctional health services at any one time. Have you guys ever watched House? You know how annoying that guy is, how he's like a neuroradiologist, an OBGYN, and a surgeon all in the same day? Well, this is really what correctional health has to do. They have to be OBGYNs, internal medicine, and they do a certain amount of surgery. They have to do it all, and I think it's really challenging. And there are between 30 and 65 juveniles in custody. So 1 in 4 persons in the correctional health services facilities has a chronic condition. So they have to deal with tons of diabetes, hypertension, and heart disease. Orion touched on the mental health conditions. 8.2%, and sometimes it's above 10%, have a serious mental illness, which is a dramatic mental illness that significantly affects their lives. 16% have a significant mental health condition. CHS receives over 4,000 healthcare requests monthly, and they conduct over 500 withdrawal checks from substance use disorder a day. So this is a huge part of what they're doing. And again, these people, this is beyond family practice. They have to do absolutely everything all the time. So this is just a screenshot. It's a terrible slide. You can't read it. But this is kind of what a snapshot of Maricopa County jails looks like. And what you can see, and I'll tell you the biggest lines there, is the very longest line is mental health and chronic care. That by far outweighs all the other issues. But you can see that there's a lot of hypertension, a lot of lung disease, and a fair amount of diabetes. So this is just a snapshot in time, but this is really what they're constantly having to deal with. So a little bit about the healthcare process. The first thing they do is when folks come in to the jail system, they have a receiving screening. Then they have a mental health screening and treatment, because that's such a huge part of this. They go through medical treatment. So they look at their chronic care conditions, what particular health needs they have at the time, and any sick calls and urgent needs. They ask a lot of questions, and I am lucky enough to have just helped to redo the entrance screening for their opioid, not just opioid, but their substance use disorder, to find out what substances they do, are they addicted, are they at risk for withdrawal, and community transition is the last piece. So in the receiving screening process, all inmates are booked and released at what's called the Intake, Transfer, and Release Center. And this is a brand new building. It looks really, really nice. The rest of our jails do not look like this. This looks like the Hilton to me. And receiving screening is really used to determine whether detainees require urgent medical attention or if they will be accepted into jail to await a court appearance. So some people get to go to court right away and leave. And then others will stay there. And that's really complicated when you're trying to figure out how to manage someone's chronic condition. So this is just sort of sorting through who's going to stay and who's going to go. And anyone who needs urgent medical attention is referred to an ER at that point. So all immediate health needs are identified through this initial screening. The receiving screening takes place as soon as possible upon acceptance into custody. So they're sent to the ER if they need something right away. Then when they figure out if they're going to stay, they do this receiving screening. Health needs are properly addressed by correctional health technicians, nursing staff, and mental health providers. There's not a lot of physicians here. It's mostly mid-level staff. And then potentially infectious inmates are isolated from the general inmate population. Mostly what we talk about now are COVID and TB. So there is a statute that requires the initial health assessment within 14 days and annually. And to me, I would have thought that this extensive health assessment would have happened sooner, but it's within 14 days. So you can imagine a lot of things can happen within 14 days if things aren't really thorough, particularly when it comes to substance use disorder. 65 to 70% of patients identified at receiving screening qualify for a priority health assessment per Correctional Health Services policy, so they're seen a little bit earlier. They also get an oral and a dental evaluation and bridge mental health meds so that if they're not seen for a while, they don't have to go off of their medications. So now I'm going to bridge a little bit into infectious diseases, and I am an ID doc who trained in public health at CDC, but my heart is local public health. That is truly where I am. And as Orion talked about his journey, it is so similar to mine. I'm going to talk to you about why an ID doc is so passionate about correctional health and also about these diseases and substance use disorder, because they are all connected. As Orion mentioned, all of these diseases that happen in jails and prisons, all of these patients are also patients with, not all of them, but a lot of them are patients with substance use disorder. So you as ID docs have a unique opportunity to see a patient when you're dealing with an infectious condition, and you may have an opportunity, maybe at that moment with their endocarditis or their osteomyelitis, where they might be ready to go on opioid use disorder treatment. MAT or MOUD. And I want you to think about this. You are internists, you can prescribe this. It is completely legal to prescribe buprenorphine. So I just want you to think about this as we go through. So the HIV population in Maricopa County, those inmates are 3 to 4 times higher risk of having HIV than the general population. And actually 1 in 7 people living with HIV pass through a correctional facility each year. So a lot of HIV. And obviously the population is at much higher risk due to IV drug use, prostitution, serious mental illness, and lower socioeconomic status. When we look at hepatitis C, they also have higher rates of infection due to their risk factors, predominantly in IV drug use. About 16 to 41% have a history of infection, and 35%, 1/3 of inmates are chronically infected. So this is a huge opportunity to get to that population. And I did double check with the CMO, and they do treat all patients with chronic hepatitis C as long as they're going to be staying for at least 6 to 12 months. And that's to make sure they can get through the workup, period of sobriety, and then make sure they complete the entire course of hepatitis C therapy. And I want to highlight something. Orion kind of talked around it, but this is something I didn't know when I was in medicine. Who pays for all this medical care of inmates? Do you guys know? What?
Taxpayers.
Yes, taxpayers. They kind of pay for everything indirectly. But actually, it's the counties that pay for this medical care. Most of these people qualify for access, our Medicaid system, right? But as Orion mentioned, when you get incarcerated, you lose your Medicaid coverage. So all of these people who qualify for this federal system now are required to get health care from correctional health systems, correctional health services, but they don't have Medicaid coverage. That really limits the care that they can get. And it is really unfortunate. And if I could snap my fingers and have one health policy thing happen, it would be that Medicaid would cover people in correctional settings. And they're slowly moving toward it. Oregon, who's way ahead of us, they just passed, waiver 1115?
Yeah, we modeled California and Washington.
Right, California's first, shocker. Yeah. So Arizona's way down the line, but they basically got it so that Medicaid will cover them 90 days before they leave. I would love to get that happening in Arizona. Looking at TB, obviously a higher risk of TB due to homelessness, crowded living conditions, HIV, and substance misuse. All patients are screened for active TB, and then if they're identified as having it, they treat in conjunction with Maricopa County Public Health. And 3% of all active TB infections in Maricopa County were incarcerated at the time. So this is an important way to identify those patients. STIs, there's a whole special population CDC guidelines that correctional health follows. Obviously, pregnant women are a population that we have to watch very closely. And so pre-pandemic and now, all inmates were offered hepatitis C, HIV, gonorrhea, chlamydia, and syphilis testing and treatment. It did not go that well during the pandemic. I don't know if a lot of you know, but the numbers for STDs actually dipped down during the pandemic. Did you guys know that? Do you think people just stopped having sex during the pandemic? Yeah, it's an artifact of testing. Thank goodness you guys are on this. So people are like, oh, chlamydia's down. No, it is not. We closed down all of our testing facilities. And so then it flew right back up after the pandemic. But I am pleased to say that chlamydia and gonorrhea are leveling off. Orion talked about this one. So here's some local data. Look, so this is a crazy graph. Don't even worry about all those colors. Look at that gray line on top. That's our latent, or unknown duration. So those are the people we flat out missed when they were earlier on in their process. And look at that line. It's all over the place, but this is from January 2018 up to January 2023. It just flew up since the pandemic, and it is out of control. And Orion, I super appreciate your showing Oregon's numbers. And this is not where we want to be number one. Arizona is number one in congenital syphilis for the entire country. Did you know that? Number one. It is so sad. So when we look at syphilis among females by pregnancy status, nearly 20%, nearly 1 in 5 women with syphilis are pregnant. So that's a lot of people who are at risk. And you can see in 2022, there were 263 of those individuals, a lot of people who absolutely have to be treated. So what does that do for congenital syphilis? And when Orion showed those numbers, I think your highest number was 37. Look at these numbers, you guys. In 2022, we had 137 cases. This is not a joke. This is something that, and I know your ID docs, and I know we hate treating pregnant patients. I hate it too. But if somebody is pregnant and they're not in prenatal care, again, there's an opportunity for you to make a difference and test them for syphilis. We have such high rates of syphilis here that prenatal testing is recommended when they first get into care, again in the 3rd trimester at 28 weeks, and again at delivery. That's all CDC recommendations, and we actually have a county order to do all of that testing. So what you can see is just vastly increasing congenital syphilis, 137 cases in 2022, and that red bar is fetal demise. So those are actually babies that just didn't make it, 16 of them in 2022. And 2023, these data were updated in the end of October, but a lot more cases usually end up getting added. So I don't know that we'll exceed it, but we still have a lot. So looking at our syphilis among pregnant females by risk factor, I highlighted 2 numbers here. One is that almost 15% have been in jail in the past year. And Orion showed you similar data from Oregon. So the vast majority of these women with who have syphilis, The reason why their babies end up with congenital syphilis is because they don't get prenatal care. Why aren't they getting prenatal care? Anybody? Look at the top number. Almost half of them use substances, right? What happens in Arizona if you use substances? And that is the fear. So the truth is, if you get prenatal care and you're pregnant, nobody reports you anywhere. But when you, but the belief of a lot of women who have substance use disorder is that if they identify that the mom is on substances, that they will then report them because there's mandatory reporting to DCS when a baby is born with substances in its system. But this is what I need you to understand. There is no mandate to report until the child is born. So all prenatal care can be given. You can start these women on MOUD, opioid use disorder therapy. You can start them on it and you never have to report them. There's no law, you're not skirting any laws. And that's what we have to get through to this community, that they will not get reported. It is only at birth that is the time when they are supposed to get reported to DCS. And if I could snap my fingers again, the second health policy I would change is that any woman who's pregnant and has a baby while she is on medications for opioid use disorder would have an automatic sort of big asterisk in their chart that says she's on the treatment, the standard of care that she needs. Let her keep her child. I wish I could change that, but that is really what's driving congenital syphilis, is the fact that a lot of these people use substances and are afraid to get prenatal care. So if 15% of them are in jail and we automatically screen for syphilis, it's an amazing opportunity to get them treated while they're there and save the lives of these babies and treat it with penicillin, which, as you know, is hard to come by these days. Okay, so I just quickly want to talk about suicide and substance use because it's such a major issue. I showed you the numbers for mental health disorders. This is some national data between 2001 and 2019. The number of suicide increased 85% in state prisons, 61% in federal, and 13% in jail. So this is going up everywhere. Most of it's suffocation, just because that's the only means they have, hanging. 12% of deaths by suicide in local jails occur within 24 hours of incarceration. What could possibly make someone want to end their life in that first 24 hours in incarceration, besides the fact that they were just incarcerated? Withdrawal, exactly. So all of these are tied together. If we don't identify who's going to go through withdrawal, I've never withdrawn from meth or fentanyl, but what I'm told is it makes you feel like you want to end your life. It feels terrible. So that is another opportunity where we have to make sure that people are getting treated appropriately. Suicide is the 10th cause of death in the carceral system. And every patient in Maricopa County is asked about suicidal ideation, and anyone with a mental health history gets a suicide risk assessment. And if there is a determination that they're at risk to themselves, they do go directly in observation, but obviously we miss some, and it's bad. So talking about addiction medicine and correctional health setting, look at these numbers. So these are snapshots. Our correctional health services doesn't have any epidemiologists or evaluations experts. That's where public health comes in. We're partnering more and more. These data are hard to come by because this is such a special population. So we're slowly building that rapport and that trust to be able to see more line level data to help them with this. But when you look January through May 2023, what you can see is on average 60% of people who enter Maricopa County jails have a substance use disorder. And how many people did I say were in there at a time? 7,000. Can you imagine trying to get all those people evaluated for MOUD and on treatment? How many providers that would take, how much money that would take? It's absolutely insane. And they don't have Medicaid. They didn't have any money to do it. So these are the types of drugs that are predominantly used. It's opioids or pain meds, which is how they describe it now. It's mostly fentanyl and methamphetamines. And what we're seeing throughout the country in carceral settings, we're doing okay on time? We are not. Okay. What we're seeing throughout the country is that most of it is poly drug use. So I just want to highlight that this program is a 7-member team to put all of those patients in MOUD. They began the program in February 2023. We actually used our opioid settlement funds in public health to fund this program further. And now you can see that the number went from 220 all the way up to 1174. And that's not even a fraction of the people who need it. These opioid settlement funds are great, but we need to have more funding so we can treat these people with the standard of care. And so just to end, these are all the opportunities that public health has to work with correctional health. You guys have opportunities to intervene when you see these patients for infectious diseases. Please ask them if they're ready for MOUD. We have lots of automatic screening in place to prevent the spread of disease in the community. And the more that public health can support correctional health with epidemiology and evaluation, the more we can improve these programs. And I just want to acknowledge the folks who helped me with these slides. Thank you.
I know that there's grand rounds just following us, but my colleague, Mariel Marlowe, had to go. She put a message there in the chat for you guys. I'll just read it out. Good afternoon, everyone, and thank you so much for the opportunity to participate as a discussant for this grand rounds. I'm Dr. Mariel Marlowe, Correctional Health Coordinator for the CDC National Center for HIV, Viral Hepatitis, STD, and TB Prevention. I sit in our Office of Health Equity in the Office of the Director. A big thank you to Orion and Rebecca for wonderful presentations that clearly just demonstrate the challenges and needs in this area. I can say from the national level, we are seeing similar situations across the country, so there isn't much else to be said. Just a plug for the CDC at a glance that summarizes CDC recommendations for correctional and detentional settings, as well as some other resources that might be helpful for you guys. Thank you guys so much. We'll be around. I don't know that there's time for official questions since our grand rounds time is up, but we're pretty friendly folks.